So earlier today, I posted some information on amniotic fluid embolism. Right now, I want to share some information on how to manage amniotic fluid embolism if it's suspected. SMFM has published a checklist for initial management of AFE. I will put this in my link in bio so everybody can have access to it. A sample checklist is presented. We sought specifically to cover the immediate management of AFE in the labor delivery unit when a rapid response is critical. Once the patient is stabilized and transferred to the ICU, there is usually more time for reflection, reading, and discussion. Therefore, management during the later stages is not covered in this presentation. So this is for the initial management. Let's go through it. The first step is to manage the circulatory collapse. So the patient will sometimes have an aura where they feel something is off. It can be during the labor process or within 30 minutes after delivery. They typically present with cardiorespiratory collapse or cardiac arrest. So the first thing is going to be your typical ABCs: manage airway, breathing, and circulation. You need to designate a timekeeper to call out times at 1-minute intervals. This is especially important if the patient is actually still pregnant, because once you hit that 4-minute mark, the kid should start coming out. Obviously, if no pulse, start CPR. Manually displace the uterus or lateral left tilt. That's even important after delivery because the uterus is still enlarged. So you need to do that whether or not the patient's still pregnant or within the 30 minutes postpartum. Make sure they're placed on a backboard. Pretty much all labor and delivery beds should have a backboard. Don't forget, anytime you're doing a CPR in a labor and delivery bed, the patient needs to be on a backboard. If you can get to the OR immediately, go ahead and start moving them if you can get there in 2 minutes or less. If there's still no pulse at 4 minutes, start a perimortem cesarean, and that's if the patient's still pregnant. You're going to splash prep, don't wait for antibiotics, and that's going to also improve the chance for resuscitation of the patient. Next, the patient's going to have uteroanatomy, DIC, and hemorrhage. So you're going to start giving the oxytocin prophylaxis plus other uteral tonics as needed. If you're having profound uteroanatomy, what I sometimes do is have one patient, one hand in the vagina, one hand on top of the uterus, just squishing that uterus together, because that's going to be one of the major sources of bleeding. But you still give the uteral tonics. Initiate MTP. Go back up here. Consider IO if needed for large bore IV access. If you can get another 18 gauge and another arm or extremity, do that. If not, do an IO. Initiate massive transfusion protocol. Cryo is preferred over FFP to reduce volume overload. It's very important to know what your MTP protocol is in the unit where you're working. Every hospital with the MTP protocol is going to have a different, what comes in each round of an MTP. In most places, you can also ask for an immediate release of blood products. Whatever you need to do, know beforehand what would get you at least 6 units of PRBCs, cryo, and platelets ASAP. Give TXA if DIC or hemorrhage occurs. Most are going to have this, so make sure you have easy, available access to TXA. You want to manage pulmonary hypertension and right ventricular failure. Consider echo, either thoracic or esophageal, and avoid fluid overload. So you want to give boluses of 500 mLs and reassess. So don't start pouring in fluids. Yes, I know the patient's bleeding, but you got to be mindful of the fluids, and most what they need are blood products. Now, this echo is not going to be done in the acute phase, but once the patient's stabilized, you can move to the echo. Start vasopressors if needed. Norepi, first line. Inotropes if needed. You can give dobutamine, milrinone. Pulmonary vasodilator if needed to unload the right ventricle. That can include inhaled nitric oxide, inhaled epoprostenol, IV epoprostenol, or sildenafil. If you have access to ECMO at your center, go ahead and call for it. Just let them know. Someone let them know ASAP so they can start getting it ready. Now, I know there's been some literature published on giving the AOK meds, atropine, ondansetron, and ketorolac, but there's really no evidence to support that. That is not something that is standard of care in cases of AFE. I will say in these cases, it's very important to assign roles, both with nursing and the MDs. I know it's a crazy situation to be in, but have drills, have simulations, interdisciplinary with anesthesia, OB, and nursing. I know it's not very common, it doesn't happen that often, but do drills. I promise you, it will help when it actually does happen. You can also go to UpToDate. They have some good tables in this initial emergency management, suspected AFE, vasopressors and inotropes, differential diagnosis, initial testing, and some other graphics. So you can also go there to get some good information as well.